So yes, welcome to the Rural Health Link sectors, and today we're talking about virtual health supports for rural BC, and we have three wonderful speakers today, and we're really excited to have you all here. So Lisa,
Okay, thank you, everyone. And
I'll just
I'm
make sure
just
you
going to
can
basically
share.
be doing an introduction today, and I'm going to be introducing some members of our Pacific Blue Cross team. Wayne Tang, who is our Director of Life and Disability, Dr. Anar Dosa, who is our Director of Pharmacy Services, and Lynn Mawangandizi, who is our Director of Policy Standards and Benefit Management. And really, these are our three experts on our virtual healthcare supports and what we use today. So I'm going to be turning it over to them, and I hope you're going to enjoy what they share with you. And Wayne, I'm going to ask if you could share the presentation for us. And while he's getting that up, or Lynn, thank you, perfect. While he's getting that up, I'm just going to start by acknowledging that Pacific Blue Cross is on the province of British Columbia and is located on the traditional territories of many distinct First Nations with different cultures, languages, and unique dialects. And we would ask you all to reflect, acknowledge, and honor today in your own way on the First Nations land on which you live, work, and play. And I really thank you all for being interested in this topic. And I'm going to turn it over to Wayne, who's going to sort of kick us off.
Awesome. Thanks, Lisa. Before I kind of really jump into it, I just want to check my audio. Everybody is hearing me. Aaron's perfect. Awesome. And so I am going to move fairly quickly. We do have a number of slides, and I know that we are a little bit tight on time, so we're just going to get moving on this. Um, I'm not going to spend a lot of time on this first slide, only that I think we all recognize that there is a universal challenge here. The dispersion of our resources within BC really creates a challenge in forming supportive infrastructure, not only for addressing illness, but also to provide long-lasting support for promoting wellness. So that preventative piece is here at PBC is really, really important. I'm sure this is a reason why we're all on this call today. So let's keep moving. Thank you. As you know, the challenges are really diverse. There's no silver bullet here, and so the solution also has to be fairly multifaceted. I don't think we are here to tout that we have the answers for everything from PBC. What I really want to do today is to share and showcase some of the resources that we have, but also what might be out there in the ecosystem that is low or no cost, that can be delivered from a virtual perspective. And so I will speak more from a disability and wellness perspective and pass it off to Anar to talk a little bit more about it from the pharmacological perspective. Perfect, thank you. So first off, just touching on the connection with a primary care clinician. I don't tout to have the fantastic solution here, but I will point out that on our website at PBC, we do have some great resources that will help folks get attached to a primary care clinician. So for example, I'm not sure you can see the typos, sorry, the cutout is very, very small, but on that website, there's the link to the physician finder tool that's provided by the divisions of family practice. There is a physician registry by a HealthLink BC for those that want to register and get in line for an available physician and or nurse practitioner. There's also a nice little link there for findadoctor.ca. So it is a good resource to have everything all in one place. And we often find for our folks, especially those that perhaps don't have connections with a primary care physician and they have a disability claim and we need some medical information, we will send them to this page to get them hooked into to the right care provider. Next slide, please. One of the options that we have available for our members over and on top of the resources that I just briefly went through in the previous slide is TELUS Virtual Care, which provides 24/7 access to a nurse practitioner. It is not a replacement for a physician. However, in times where the options are limited or at 3 o'clock in the morning, it could be really helpful for us. And so I myself have some coworkers that have utilized this particular resource. for timely help for some of the children at untimely things that happen at 3 in the morning. Next slide, please, Lynn. Awesome, thank you. Switching over briefly to disability claims, and that's the bread and butter in terms of my day-to-day reality. We know that the resources required to manage a disability claim and get someone on the road to recovery, we want that access as quick as possible. And I think the reality is just that the resources just aren't as dense, obviously not as dense as certainly in the urban areas. So just a call out here that there's an immediate recognition that if you were to be, so unfortunate to be on a disability claim, that there should be an immediate recognition that reimbursement for travel and mileage is just part of the recovery plan. And then for those that perhaps can't travel right away, or just for extenuating circumstances, the travel is just not possible at a specific time. Unfortunately, at that point, we would rely primarily on our virtual health network. Next slide, thank you. Now, as we all know, there will be specific services that really can't be delivered in a typical community-based setting. Even in an urban setting, these services might be difficult to access. And what I'm referring to are specific medical investigations, perhaps a specialist that has to, for a particular ailment that you might have, or they may be specific rehab programs or services like a multidisciplinary pain program or an addictions-based service. Those are all really complex types of programs and recovery-based services that unfortunately require some level of travel, sometimes travel and accommodation if you are going to be getting some services that are a little bit more long-term. One of the things that we have to be very cognizant of from a disability provider perspective is that we need to weigh the impacts. We have to think about the financial impacts for us, but more importantly, the personal impacts for our members. Like there's the logistical issue. I mean, if they're in the middle of some remote region, just getting to an airport to get to the service may be an ordeal in itself. And with that, a lot of times we will talk to our families or members to talk to their families because they may be leaving some young kids for a period of time. They have to think about childcare. They have to think about who's going to pick the kids up from school, all those kind of things. Those are all practical issues that we, in my department, we deal with on a day-to-day basis. Next slide, please. Thank you. So just touching on travel, since we're talking about it a little bit, there are a couple of services or resources that I'd like to highlight. For those that may not be aware, there's the BC Travel Assistance Program, or BC TAP, and that helps cover partial costs, if I'm not wrong about that, for travel to access specialist services. PBC, in terms of through its Health Foundation, also supports several nonprofits. You can see them on the slide there. We have Hope Air, which supports folks with of low income, and they have access and provide services to rural and remote regions. There's also a really cool service that's offered by Helicopters Without Borders, and they operate a fly-in dental clinic to remote communities. So those are actually really fantastic resources. Next slide, thank you. Switching gears again quickly, I want to kind of talk about some of the virtual resources that we promote through our wellness programs here at PBC. These are going to be as much as possible free or low cost types of services, and certainly perhaps something that your community might consider if you don't know about them. And I would recommend that you check them out. I was talking to Sam, who's our senior manager of wellness here at PBC, and he was just saying anecdotally, some of these, one of the challenges is that there isn't necessarily a lack of resources virtually. There's a lack of awareness of resources. So a lot of the resources that are there are, in his perspective, underutilized. So part of the hope here is to create a little bit more awareness so that you can share with folks and maybe drive a little bit more traffic through these resources. Next slide, please. Awesome. First is Y at Home. So Y at Home is a virtual service that's offered through the YMCA. And they have fitness resources and workout plans and meditation kind of sessions, general activities for all ages for both children and adults. There is a free version. There is a paid version. There's a Y at Home Plus version that can be paid for that offers, I think, a little bit more of a robust service, but certainly a good starting point if you're really looking to get into activity and wellness, where perhaps access to a community-related kind of service, like a community center, might be hard to access. And as we know, the majority of a lot of our chronic illnesses are preventable through activity and wellness. So this is a great option. These folks were actually just in our office yesterday, speaking to some of our folks around how they want to create a more robust service. And so that's fantastic news. I think they're just throwing around ideas of how they can be a little bit more relevant within today's kind of growing industry trends and how they can provide better services, perhaps to some of our members and the general public. Okay. PBC itself, if you actually come to our website, we have a variety of mental health resources. There's this improved mental health checklist, and there's also some free links that I would encourage folks to check out. And this one is kind of cool. So this is a group called Heads Up Guys, and I believe that it was developed from a psychologist coming out of UBC. And it is a mental health service that really caters to the gentleman. And so in real recognition that men's mental health is actually a growing issue from the perspective of just managing their mood-related issues, specifically kind of suicide awareness and suicide prevention. This particular program has really grown in the last little bit. I would highly encourage you to check out their website. They've got some really great resources, not just for those that perhaps are going through the experience of mental health challenges, but also some great resources for those that are looking to support the men in our lives, and how to kind of have that conversation, all those kind of things. I asked a specific question around, hey, like I've got a group of guy friends who are really close to this particular individual I want to reach out to. How do I do that in a way that's really going to be sensitive, but also perhaps not putting them off from the perspective of just our guy relationship that we have? Like we usually go for beers and play pool. Like how do I kind of start that conversation? I find that really challenging, and they were able to, give me some really good advice on that. So I think this is a really cool service. Okay, and last slide. So last one I want to cover is Health Connected. This is another service that is offered through for our PBC members. It is a digital wellness tool that's offered for both our group as well as individual plan members. One of the services that I'd highlight is the health risk assessment. Sam, whom I mentioned earlier, is a huge supporter of this. This is one of the services that he really kind of pushes when he's talking to his employers and other external stakeholders. It provides some good assessment of health behaviors and flags risks and risk factors and gives some tailored recommendations around sleep and exercise and diet and whatnot. So I know that it was fairly quick. I think I'm within my time limit. So I think what I'm going to do is pass it off quickly to Anar.
Okay, great. Thanks, Wayne. And good afternoon, everyone. Thanks for the opportunity to share with you what resources are available that could be utilized perhaps more widely than they are. The first item that I wanted to talk about it. This is a program that I was involved in a couple of decades ago, early 2000s, and it's nice to see as I was researching some programs that are available to British Columbians, this continues to be available. And for those of you who may not be aware, this is Self-Management British Columbia, and this program has evolved since I was involved with it back a few years ago. They have this program available in multiple languages. So you can see on the slide here, it's very tailored to multi-ethnicities, very multicultural here in BC. So they have taken that into consideration and expanded to address the questions that might be faced by other communities that are living in BC. This program is also available for various different conditions, including chronic pain, diabetes, cancer, and available through various different areas within the province. If you go on to the next slide, they have various different modes of communication. So for someone that likes to study on their own, head down, figure it out on their own, there's self-study programs that come with good, credible information. And then there's people who want to do things virtually because of where they live, or they just prefer that method. This program is available over a 6-week session, 2.5 hours per week. So it is a significant investment for 6 weeks, and they're relatively small, 5 to 8 persons per group. And then there's in-person sessions. So I've been involved in more of the in-person sessions where people come in, and these are held at community centers, offered over 6 sessions, 2.5 hours per week for 6 weeks, and small group sessions here. And what's really interesting about this is that really people feel like they're learning from the facilitator, but they're really learning from each other because they have this condition. People are at various different journeys and can share that information, and people just learn so much more from someone who's lived through that experience. And so this is probably why these programs continue to be available, because people find them very worthwhile. And then there's people that just don't do anything on their computer and just do everything on their phone. An example with that would be my dad. He's just always on his phone. And so this program is also available to people like him. And this is actually one-to-one coaching, where you receive a call from a health coach for half an hour once a week for 3 months. So significant investment going into this programming that's completely free, paid through our tax dollars, and very cost effective, because these programs have had outcome measures. And because the outcome measures pointed to good outcomes for people, reducing admissions to hospital, reducing the need to go and look for higher type of care. There's a lot of prevention involved in some of these programs here as well, and for that reason, they continue to be available. On the next slide, just wanted to let you know about another program that is completely free, paid through tax dollars, called the Pharmacist Clinic. That's based out of UBC, so it's physically located at the University of British Columbia, the Vancouver campus, but the program is available to anybody in BC and in fact in Canada, and they can provide the service remotely. So they answer questions, they have a team-based approach, make sure that they also ensure that they communicate with your primary care provider so that they're kept in the loop of what's been discussed and any suggestions that they might have. It's referral-free access, so you don't need, we're trying to reduce admin burden for prescribers having to fill out forms and things like that. Well, here's a program that is actually referral-free. So if anybody has any questions about medications, etc., there is generally no cost to get that information. And this is a prototype that has been used to establish primary care clinics that are now available around the province. So that's a resource that many people are not familiar with. So I thought I would share that with you. And then if we can go on to the next slide. As a certified diabetes educator, I've been in this space for over 30 years. Many people don't realize that diabetes can be prevented in many people. Yes, there is a genetic component to it, but much of it is something that can be prevented. And this statistic here shows that over 50% of people with untreated prediabetes will develop type 2 diabetes in 8 to 10 years. So if you go on to the next slide, Diabetes Canada, because of that statistic, recommends that an A1C, which is a blood test, be used to screen for diabetes and prediabetes every 3 years for anyone who's 40 and over. And so because I've been in the diabetes space for many years, I can tell you that that number used to be a lot higher. But because of the incidence and prevalence of diabetes, that number has now been reduced from like 45 down to 40 because we're seeing diabetes come up early and earlier. And yes, Ed, I knew that you would like this information, particularly in the area of work that you're in. And I know that you're trying to promote this type of prevention so that we can hopefully bend the curve on diabetes prevalence and incidence. Going on to the next slide, we've partnered with an organization called Lifestyle RX, which is again a completely free program that's covered here in BC, but also in Alberta and Ontario. And it's a 12-week program that's free to access and can help people with managing not just their diabetes, but all of the other stuff that goes along with diabetes. And there are group education sessions, one-on-one sessions. On the next slide, it gives you a little bit more detail. So it's a 12-week program. There's virtual physician visits involved. There's group education sessions and then videos and things like that. So it is an investment. This is not easy to do, especially if you're looking to bring your sugars down and perhaps come off medications. I've seen this done in my own practice, but this is something that is now has more research backing it. And so this is something that that is available for people, and they track your results. I've known of people that have gone through these programs, and again, group education, that theme seems to be coming up in programs that are successful. So people like to learn from each other that have gone through these types of conditions. And I think I might have, yes, one more slide on medical weight management. So we know that there's a lot of interest in the anti-obesity drugs, right? So we're inundated with social media that's telling us just ask your doctor to write you a prescription for Wegovy or for the newest one is Zepbound or Ozempic, etc. And so in doing the research for how we wanted to address this within our organization for our members, I discovered this program called Medical Weight Management that's based out of Coquitlam, run by a physician who has an interest in obesity management because he himself is going through that journey. And he's actually now looking at retiring, but hoping to pass this knowledge over to the newer physicians. And so there's a medical management component, a lifestyle management, mental well-being, again, completely free, but it is a referral-based program in order for them to be able to access MSP resources to be able to do the work that they do. And I've actually attended one of their group education sessions. So this too is a group model and one-on-one sessions as well. So just thought I would share that information with you, and I'm going to hand it over to Lynn next.
Hi, sorry about that. And I couldn't find the screen to unmute myself. My name is Lynn Monganize, as mentioned, and I wanted to just do a quick overview of the things that we do work on internally. So Anar and Wayne, excuse me, have just shared some of the resources both internally and externally, and I wanted to just give you a quick highlight on some of the things that we have from our plan specific benefits. One of the things that is recent and new and we're excited for is a launch with our partnership with Sano Midlife. This is an organization that has lots of resources that are geared toward people going through midlife. And so sort of menopause and perimenopause and premenopause are sort of the terms that are generally used. And it's really trying to engage individuals early with resources to even just understand the differences, the different ways that they might be feeling this, have resources and ways to also deal with some of the symptoms that they might have or questions. But in addition to some of those resources, you can also have access to a health coach or a nurse practitioner, physiotherapist, and other type of practitioners to help you deal with some of the symptoms that you might be feeling or experiencing. One of the ways that we've partnered with them is this is available to all of our plan members, whether they're on our group plans that are employer sponsored, but also even on our individual plans. And we also have negotiated some reduced rates to ensure that people have greater access to some of these services as they need them. And speaking of some of those paramedical practitioners that they might need, we've also taken an approach and sort of looking through our different benefits and ensuring that wherever there is college regulation allowing for a capacity for telehealth or virtual processes for providing those services, that we also allow it on any of our benefits. So this is just a quick overview of some of the benefits that we allow for video or teleconferencing so that it helps to ensure increased access for people that might not be able to access them in their areas. But also, it's not just about remote or distance, it's also the time. So we know that when someone needs to visit a provider at the different times, so examples in terms of 5 o'clock in the afternoon versus in the middle of the day, having a virtual option available allows people to actually access that at an earlier time. And then sort of similar questions around, if you needed to go visit a practitioner elsewhere and you need to organize for childcare, or for other people, it's actually for their own transportation. So if they've got accessibility needs, this can help to reduce that impact on their ability to access care. And so we've really taken an approach in looking at all the things that we cover and ensuring that we allow for some of those virtual options on the areas that we know that have a positive outcome. We know that not everything can be administered virtually, but this is us trying to always keep up with as technology advances and abilities within our provider groups also increase, that we allow for those opportunities. And then the last piece is just also we talk about sort of virtual options from the perspective of the service that is being provided. But one of the things that we also know in terms of allowing for access to care is things such as direct billing. And so we continually work to ensure that our members are not out of pocket for services wherever possible, because even that additional impact in saying I have to pay for something first and then get reimbursed can actually impact access to care for individuals. And so this allows us to help to ensure that people have access to some of those services that might be expensive. And we've thought about it from more of a holistic perspective, and not just, well, if it's over this amount, that's the only time we'll pay. Because while we know that, yes, large amounts, so for example, on medical equipment and things like that, that large amount of money might be an impediment to accessing some of those services. Some of the things that we might consider as low dollar value might still be an impediment for someone to access care. And one of the things that we're really proud of and thought through as we were adding this was clinical counselors. And we know from a mental health perspective that, whether it's $100 for a session, that $100 could be an impediment because someone might literally be going through some of those mental health circumstances because of financial issues. And so reducing that is helpful. But we also know that the process of submitting claims to your health insurer for someone who's going through a mental health episode might be a large undertaking. And so reducing that barrier for them to be able to still access the services that they actually need, which is seeing their practitioner and not having to worry about then submitting a claim and sending that to us and waiting for us to submit to provide that reimbursement even though we try to reimburse within 3 business days, again, that 3 business days could be a significant waiting time for someone who might have financial challenges and or challenges in terms of getting those claims to us. We've also expanded this for our sleep equipment providers. Again, these are some high cost materials that we know that other people might not have the ability to pay for that upfront and then get reimbursed. So ensuring that we've got that access to care for individuals that need those services is one of the ways that we continue to support our members. On our website, we also have an InstaClaim search tool, and this also allows individuals to find practitioners or providers that are able to bill us directly within the community. So if you go on our website, you can search based on an area, and then I'll tell you if I'm looking for a chiropractor within my area who bills us directly, then that would show that information as well. And that will help for individuals to find people within their community as much as possible that are able to direct bill us. So you've got access to a provider and access to those services without having to pay up front. So I know we've kind of gone through that a bit quickly. We were trying to get as much information out to you as possible, but opening it up for any questions or comments, really appreciate getting some feedback from this team as well. Anton.
Good afternoon, everyone. Anton Meyer. I'm a family physician that's repurposed and focusing on system transformation. Congratulations on sharing your story, and Lynn and Anar and Wayne, thank you for giving us the wide spectrum of services that you provide and deliver. I appreciate, Wayne, when you started off by demonstrating tangibly how Pacific Blue Cross tries to connect with the division structure, and when a patient seeks care, try to connect them with their patient family home or their primary care provider. So when I see all these beautiful pockets of work that you are doing, and so many of them, which is great, what effort are you taking to connect all of these in an interconnected way, that the information gathered by all these various beautiful places does not continue to land in silo approaches, but be reconciled and integrated into a longitudinal place where we know when the continuity is there, the patient really benefits. And if we don't do that, it leads to significant safety and harm issues to patients. Do you have a focus on trying to integrate these information areas through your programs that can go back to the patient medical home? I'm curious to hear if you have that as a focus, and how do you do so?
Okay, so Wayne, I think I'll give a little bit of a background. So our focus is to bring a lot of these resources together in one place, which is all on our website. Many of these resources that we have talked about are free to the public. So there, you do not have to be a Pacific Blue Cross member to be able to access these resources. For the longitudinal approach that you're talking about, we are doing some work right now. It is very, very, I'll say in early stages in terms of trying to bring information together for patients and their care, so all of their care providers into one place. But yeah, like I say, we're very early. We're just in the process of doing a pilot at this point in time, a proof of concept pilot to see whether this will work, and hoping that the learnings from this will be able to share out. But to your point, we agree with everything you're saying. Our initial approach has been trying to bring it all together, at least on one website, which is Pacific Blue Cross, that you could go search and get as much information as you can. And I'm happy to open it up to any other members of our team to be able to provide any other insights.
I would just like to jump in quick and to make sure that we get to all the presentations that so that we'll, if there's some follow-up, maybe just hold it in your mind just so that we can hear from Dr. Kendall and Dr. Anurag as well. And so I'm just going to interject there. Thank you so much for that answer, Lisa. That was amazing and great question, Anton. You can always get the best questions from Anton. He's a real thinker, that guy. So, and I love it. So I'm really excited to move forward with the next presentation is from Dr. Kendall Ho. And I will put a link in the chat as if you want to learn more about who he is and all of our presentations today. But yeah, the floor is yours, or the Zoom floor. Thanks.
Wonderful. Thank you so much. Really appreciate the invitation. It's my distinct pleasure to be here to share some thoughts on virtual care. Especially, my understanding is I'm focusing on virtual care research. So I just want to make sure that you could see my slide. Are you able to do so, Sarah? If you can give me a thumbs up. Oh, I see it, Anton. Thank you. Really appreciate the Pacific Blue Cross presentation. Excellent breadth of the different kinds of virtual care intervention. I'm going to take a slightly different tact to say, if you have an intervention on a website, how does it demonstrate that it's effective? What are the types of research or generation of evidence to support that? So that's what I'm going to focus my presentation on. I'm hoping to do this in about 15 minutes and then have 5 minutes of Q&A so that Anurag will be able to also share this time with me. Virtual care, really, it's a technological approach. Really, at the end of the day, is to enable supporting services. As Pacific Blue Cross has demonstrated many of the intervention in the rural communities. And in virtual care, really is about how can we help. You must have met Dr. John Palovich. That's his favorite saying, and truly, it's a very, very important saying. So for the patients, the pictures on the left, for the patients in emergency department and colleagues, how can we support them? And what can virtual care do? And I really want to give a big nod to RCCBC and also all of you, because I think there's so much community-based generation of evidence in British Columbia, and it's incredible how much you have contributed to it. And I'm in some ways trying to collate some of those information today and also do some research with all of you. Telehealth or virtual care. We have certain thoughts about what it is. This is a literature-based definition of virtual care. It's a bit of an older paper from New England Journal of Medicine, but really they look at virtual care in 3 ways, or telehealth. Number 1 is direct patient care. So a health professional with a patient at a distance delivering care. Many of the Pacific Blue Cross examples are in this kind of area. Secondly, it's peer-to-peer, so that it's health professionals on both ends, and then by talking together, we support patient care. And then the third is there is a set of data, and both the patients and the health professionals look at the set of data, and then they co-manage. For example, blood glucose, where you can put it onto an app, a patient shows the glucose, the health professionals see it together, and they talk together. So really, those are the 3 types of virtual care. So what I'd like to do in the next 14 minutes is to use 4 examples to look a little bit deeper into what research in those areas about. The first you may well be very, very familiar with is real-time virtual support, especially the peer-to-peer aspect of it. Secondly, I'm the medical director at the BC Ministry of Health, HealthLink BC. If you pick up the phone and call 811 and you talk to a nurse and the nurse feels that you may need to see a virtual physician, I and my colleagues will be at the other end talking with you both by phone and by video. The third is using sensors and wearables. What are some of the ways to do virtual care and what's some of the evidence that we generate? And then finally, of course, everybody talked about AI, so I figure I'll talk a little bit about AI. And the issue around the discussion is to go a little bit deeper to say, what's the evidence? How do we demonstrate it? What does research do to contribute to effective tools to help patients, especially in rural remote communities? Real-time virtual support, RCCBC tremendously in leading that network overall, and also look at the peer-to-peer pathway. I'm just going to do a quick introduction. If you have questions, I'd be happy to talk more about it. Dr. John Pavlovich, Dr. Ray Markham, John Ma, and a group of physicians all working together on the orange line. These are instant access pathways. So for example, if there's a nurse in a First Nations nursing station or rural physician in a rural emergency departments, that they can instantly access these peers, these colleagues who have physicians who have experienced an emergency, full service primary practice, maternal and child care, pediatric care. They can immediately access and talk peer to peer, health professionals to talk about how to manage certain cases. And then the green versions are the quick reply pathways. For example, being able to call a neurologist on because there's a person in stroke, a cardiologist where there's chest pain, where there's pain and there's a pain specialist. Again, all these services are currently available over the last 5 years through real-time virtual support. So really a very great set of services, and it's continued to expand and look at how to do this peer-to-peer support. How do we generate evidence to demonstrate that this is helpful? One of the ways we do it is what we call evidence-informed storytelling. Often I quote statistics, people fall asleep. If I tell a story, once upon a time, then people suddenly wake up and say, oh, there's a story here. Well, here's a story about Dawson Creek that was published in 2021. That's when there was starting to have emergency department pressure, and overnight we were having trouble covering the department. And so the Rudy line, or the real-time virtual support Dawson Creek. And this was the story about real-time support supporting 39 overnight shifts in the Dawson Creek in 2021 that led to today this service called Vera that keeps emergency department open in the rural emergency department. There are many such stories. For example, RTVS supporting the birth of a child, a baby in a rural community that has not happened for 20 years. It support the management of, for example, in a school when there are several children who were having carbon monoxide poisoning to be able to help treat those patients in a rural emergency department. So these are important storytelling that is important to form the basis of the evidence. Health professional experience is very important. And so again, we document, we interview physicians and say, what are your experiences in these areas? And so again, these are the type of publications. I'm just showing some of the publications we've done in RTVS to demonstrate how we try to document these evidence. Of course, patients' experience is very important. And in this particular paper, especially about economic paper, we document how RTVS as a system save patient cost. You can see there's a map in terms of the patient's postal code and the closest health services delivery points, such as hospitals or clinics. And by looking at 5 years of RTVS, we've demonstrated that with this model in estimating costs, we have saved patients $34 million over the last 5 years. And we also are starting to calculate the carbon dioxide footprint because of the travel that virtual care has saved. Here's about health system benefits to look at how real-time support really improve health quality and access, equity of access of care. This is one such diagram where we look at how many patients. The color coding is based on number of patients served per 10,000 population. And so the lighter the color, the less people that we've served. You can see the scale from 0, blue, and then to yellow. And then red is where 60 persons per 10,000 access point. You can see at the northwest corner, there's actually a region that suddenly lights up a lot. And in fact, RTVS has been supporting the nursing stations there and also the patients there. And so this is a way for us to look at equity of access of care. How do we support patients through these activities? And then we were able to do a 5-year summary in the Canadian Medical Association Journal to actually look at not just the individual stories, not just the physician experience, patient experience, health system benefits, but really actually summarize it into an article. I know I'm going pretty fast on this. I'm very happy to share the slides with you. You can look up the articles anytime, and happy to share those. I'm going to move on to 811. Often, when a patient has a health urgency, a mother with a 3-month-old child with fever and vomited twice, always happen on Friday nights, by the way, or a person with family history of heart attack for the first time had chest pain. The question in their mind is, boy, do I need to see a health professional now? Or can I wait till the morning to call my family doctor? Or this is something I can ignore. Or I should drive to the emergency department right now. And so in those times, having virtual care, such as an 811 phone number or virtual care, would be very helpful in those instances. And so and both the RTVS, the peer-to-peer, and also this line was started in COVID. And we've been seeing that our service with a group of virtual physicians partnering with our nurses in 811 to support our patients. 80% of the time, a telephone call is adequate, but 20% of the time, having a video is invaluable. Hey, doc, I got a cut on my face, and it's a little bit jagged, but it's clotted now. I really don't want to go to the emergency department. I need to drive 2 hours. Do I need to have that sutured? And so having a video is going to be invaluable to help in those situations. We've seen 220,000 patients now over the last 5 years. You can see the service increasing year to year. But is bump in seats enough evidence? What we try to do is we try to not only describe the service, and so these are 2 papers that describes in 2021-23, but also we did a initial first year analysis. And we found that for 3 out of 10 patients that called 811 and we encountered them, we need to accelerate them to go to emergency. Hey, your chest pain is worrisome. Don't wait till the morning. You got to go now. But in 7 out of 10 cases, we're able to safely divert them away from emergency department. And so we continue with that 5-year analysis. You can see similar type of data that you can see on the graph in the middle. It's about the annual volume of patients. And then the color coding is the maroon is go to emergency departments. The bright red is go to see a physician same day, like a clinic. If it's not open, go to emergency. And then the orange is to go to see a physician within a week. And then the green is you can stay home unless your symptom worsen. And then the rightmost graph is just to average out 100%. You can see a percentage breakdown. It's important for us to look at these numbers, but more importantly, we also look at concordance. If a physician says to the patient, please go to emergency, would the patient actually go? And so we look at this concordance of whether the advice is in the same vein as the action taken. And so we use our database to look at that. So we use a different evidence model to do that. On the left, you can see they are both what we call Sankey diagram. And so on the left is when the physician see the patients, and then you can see the color coding on the right side of the bar graph. Go to emergency, stay home, go to see a family doctor. So that was the input side of people going there. But you can see the graph on the right, that if we recommend them go to emergency, over the next 24 hours, 65% of the patient actually went to emergency department. When we recommend go see a family doctor in 1 week, we found that 50% of the time, patient would go see their family doctor within a week. So the question is it Dr. Ho, give really bad advice, forget it, I'm not going to go? Or because they said, well, going to emergency department means a 2-hour drive and it's winter and snowing out there. I really don't want to go. So are there systemic factors and other factors that affect this concordance? And so very important for us to understand that and so to continue to improve on it. That's another way for us to generate evidence. We really want to make it into a dashboard. we all very used to dashboard in COVID. How many people go get COVID, how many people hospitalized, how many people ICU, etc. So in the same way, in this real-time virtual support and 811, we want to create this dashboard so that not only do we look once and say, wow, the concordance rate is 55%, but if we change in a certain way, as the province has more and more family doctors, do we see that rate going up so that when patients call up their family doctors, they can be seen within a week easily? Would that change the statistics? And that dynamic learning health systems, how are we going to track it? And we're really excited about this study, and we just got published on Monday. For the first time, we're able to demonstrate that over 5 years, 811 actually reduced patients' volume going to emergency department. A lot of people always said, yeah, people call 811, they don't necessarily need to go to emerge. And so when you said avoid emergency visit, that really didn't make a dent onto the emergency department overcrowding on the input side. Well, we're able to now generate a paper that actually demonstrate reduction of that. And so those are the types of things that we really need to try to demonstrate. I'll try to accelerate and finish in about 2 minutes. The sensing and wearables. I learned from a Boeing engineer that the 787 plane has 840 sensors. So when the plane flies, they always track how well the plane's doing. And if one of the sensors show that a equipment is malfunctioning, it will call ahead to the next airport. So when the plane lands, the parts available in the airport are ready to put in the plane, so it'll continue to fly again. How do we apply that in humans? How do we apply it to us so that, in fact, we can benefit from that? So in 2019, we're looking at heart failure patients. As we discharge them from emergency departments and from hospital, we give them vital signs monitors at home, and we want to see if it actually reduces emergency department visit. And we demonstrate that there's a good number reduction, and patients feel more satisfied being monitored. After COVID, that was before COVID, and after COVID, we have looked at people who present to emergency department with high blood pressure. Again, what we do is we give them a high blood pressure machine and go home and monitor the blood pressure effects so that over the next 7 days, when they're waiting to see the family doctor, we track it. And if in fact it's going too high, we actually bring them into a hypertension clinic earlier on to treat them. This is a study where we put monitors into patients in the waiting room. We really are devastated when we hear any emergency department with a patient dying in a waiting room while waiting for services. We don't, by the grace of God, some of our emergency departments haven't had that happen yet. But the fact is, the longer the waits, the more risk we take. And so how do we use monitoring to keep our patients safe in the waiting room? This is one that we're quite excited about in virtual care. One of my problems when we do virtual care, like what we do today here, is I can see you, but I don't know your vital signs. I don't know how fast your heart rate is, what's your blood pressure. And this is a collaboration with National Research Council, where if the patient put their face in that green circle, I can use their camera and I can use software to detect their heart rate, to detect their oxygen saturation in the blood pressure, and the temperature. And so I can now validate what they have in terms of vital sign without them needing equipment. In research, we also always worry about policies. So these are a couple of those policy papers. One is, what is virtual care in rural emergency department? When is that limit reached? When do we need to hand it over to in-person care? And so this hybrid care integration is very, very, very important. And so how do we, as Anton really rightly pointed out, rather than fragmented services, how do we link them together? Finally, 1 minute AI. I use AI so that it can generate the picture. I asked them, generate Dr. Ho, but 30 years younger. So that was the photo. I've never looked that good, but I'm going to claim I'm going to look like that. So AI is really a computer doing able to replicate some of the thinking, reasoning, and self-improvement. And so in that area, this paper we didn't do. All the other papers, we are part of that research. But this one demonstrates that AI can support patients in making better decisions. But it's very important that health professionals partner with the patients so that it can do a better job to eliminate hallucinations. So very important paper. And so we're looking at, for example, population health screening, using AI to screen for community blood pressure so that we can manage them better. Looking at patient stratifications. Can AI help us in determining whether a patient needs to go to emergency department or not? With the AI, they will give us a recommendation, then we'll talk to the patient. That saves time for the patient, help us to make a faster decision. AI for clinical decision support in the emergency department. For example, I come in chest pain with these characteristics. What would be my 30-day mortality and how urgently I need to treat this patient to reduce their mortality? And finally, AI and patient monitoring. All the monitoring, for example, in the emergency department to understand when do we detect illnesses and how do we make sure that we support them. And AI has policy implications. What are some of the ways that we can use AI, and also how do we explain the usability and opening that black box? And so right now, one of the things that we've been doing in UBC is we established an AI and Technology Enhanced Care Collaboration Center, or AiTECCC. We want to work with policymakers to support AI policy. We want to work with you and work with our community members and also patients and caregivers, Indigenous communities. How do you use AI today? What are some of your aspirations, anxiety about using AI, and how it can help professionals support you better in AI use? And so if you're interested, please go to the website. Love to engage you all in one of our focus groups to discuss about your thoughts about AI. And so I'm going to wrap up now. Emergency department where I work as an emergency physician really is a bridge between home and hospital. For many people, the bridge is actually like a creaky bridge with gaps in between when they go home from hospital. How can we use technology to make that bridge smoother, to support our patients going home, and so that when we and the patients are no longer in person, yet technology binds us together? So how can we help each other to make sure that we have better health? Thank you very much for your attention, and sorry I went over longer than necessary. Thank you.
That was amazing. Thank you so much, Dr. Ho. We're going to we'll hold questions just so that we can get to Anurag. And then at the end, we're going to have Kathleen's going to lead our Q&A. So she's getting ready for that. And Anurag, the floor is yours. Thank you so much.
Hey, thank you very much. And thank you for the invitation. And it's kind of hard to go after Kendall's amazing presentation. Thank you, Kendall, and thank you, Wayne, for that. Okay, so little switching gear. So my title is Bringing Care Closer to Home and Strengthening Rural Indigenous Healthcare Models Through Hybrid Care. So actually it very nicely transitions to what I want to talk about is virtual and hybrid model and how it interfaces with the human element. So my name is Anurag Singh. I live and work on the traditional unceded territory of Lheidli in Prince George, and I've been practicing in northern BC as a kidney doctor, nephrologist now for about 12 years, and qualified as a nephrologist for about 15 years. So great, really grateful to have this opportunity to talk to you today. So just an overview, I just want to do nothing new to this audience, challenges in delivering from my perspective, kidney and chronic disease care in rural, remote, and Indigenous communities in northern BC, where I work. I want to share some sort of highlights from a study we've just literally wrapped up, which is just accepted for publication, and very nicely highlights the importance of hybrid care. So I want to share that with you, and also talk a little bit about an emerging model of care, which is not new, hybrid care, which is a marriage of both in-person and virtual. Virtual is great, but we need both, and share how the emerging hybrid care research collaborative, which is kind of going on in BC, is working towards co-creating solutions with the communities in northern BC and elsewhere. Just the context. So, I live in Prince George, but I serve a lot of rural remote communities in northern BC. You can see in the map here, Prince George is kind of on the southern side of northern BC. It's north central, and there's a huge province on top of us, and there are at least 59, 55 First Nations and many kind of chartered Métis charter communities in northern BC. And this is just the north I'm talking about. So that doesn't mean there are a lot of rural communities in the interior, on the Vancouver Island, and on the coast. So we have a huge geographical context, and really the challenge being that there is, we know, increased prevalence, and what I've seen with my own eyes, poor outcomes from chronic diseases in northern BC. So I'm switching gear from emergency critical to chronic disease management, which, it's not always, coming up as the main problem at that moment. So may not be with chest pain or something like that, but does shorten people's lives if it's not managed, like diabetes. There is lack of equitable access to both primary and specialist team-based care. It is very expensive for patients and families to travel for specialist care. And there is, in today's age, heavy reliance on virtual only visits. And yes, there is a potential for harm and health equity challenge when it relates to virtual only care. So I'll talk a little bit about that. But before that, I mean, kidney disease, like with most chronic diseases, it is on the rise. It's 1 in 10 prevalence as it is right now, but it's increasing rapidly, and a lot of it is driven by diabetes and other chronic diseases. We have over 50,000 Canadians with end-stage kidney disease on dialysis, and that's an ongoing worsening problem for just the budget and so on. So the problem with kidney disease alone is on the rise. And back in 2013, when I first came to Prince George, telehealth was the cool thing to do. So we set up like a telehealth clinic in Prince George. It was a team-based clinic, and we connected to 28 sites across northern BC using kind of proper telehealth equipment. And we looked at the outcomes. And really, the idea was to have the patients to have more choice. It was never meant to be a virtual only option. It was meant to be an adjunct to face-to-face visits. For instance, in winter, people cannot travel. We would see them on telehealth, but never ever kind of contemplate that will be a virtual only visit. And it was really to prevent lapses, maintain continuity of care, and so on. And of course, we wanted to look at the outcomes to standardize what we call virtual care delivery in chronic disease management. And we developed this in partnership with primary care providers, a lot of engagement with RCCBC Care, Scanny Family Services, divisions of family practice, got their feedback on how to develop that. And we also, as a part of it, had case conferences, educational sessions, case reviews, group visits, and so on. And we still do. So the context, switching gear a little bit, northern BC has the highest number of home dialysis patients in North America, period. I mean, if you look at the graph on the right, this is Northern Health Authority, and we do have geographically interspersed population, but we happen to be the one which is way ahead in terms of home dialysis prevalence. So we have at least 52% of our patients do dialysis at home. And it takes a lot of effort from the team to keep them at home and maintain them at home. So this is, for instance, one of our patients. He's on home hemodialysis. The other modality that people use for dialysis at home is called peritoneal dialysis, where they have a tube in the belly and they do their own dialysis on a regular basis. And essentially, it's sometimes the only option for people who live in rural communities where they don't have a hospital where they can go and have dialysis done. It does require hands-on training. It requires bonding with the team, trust, and of course, there is a cultural safety element, which is really important, and that's something we're realizing. Now, peritoneal dialysis has a potential complication, which is infection, which we know from our data previously, every patient could have a PD peritonitis, an infection associated through their catheter once every 2 years. And that's easily treatable. And what we noticed between 2021 to 2023, there was a huge change in the prevalence of infection rates in our patients on home-based peritoneal dialysis. That was way above the prevalence that was anywhere else. And that was a sudden change. That was not like a phenomenon we had seen before. That really confused us. So we wanted to really dig deep and really understand what has really happened. So this was a design of a study. I mean, I won't go into too much detail, but 2021 was the start of the pandemic. And that was the time where we went from our telehealth, where a combination visits where people would come and see us. It was very social, at least once a year, sometimes twice a year. Other times their appointments would be virtual, to a complete virtual appointment, and that too many times on the phone. There was no Zoom at that time, so people could not go to the local healthcare center or the facilities. So they really had to rely on a cell phone or a phone. So we looked at our own data and really had an additional study where we called patients as a sub-study. We got ethics approval to really interview some of our patients who'd gone through that journey. So this is, again, I'm sorry, I'll try to sort of say it more like a story rather than a graph, but really our patients who were undergoing peritoneal dialysis, peritonitis complication, there was a large representation for patients who were living in indigenous communities. So they represented 33% of our overall cohort, yet the infection episodes, they were largely in those patients living in those communities. And we realized it was the technique. So how they were doing dialysis and or breaks in technique was the main factor. But in addition, three other main factors came into light. Number one, on this graph, you can see that the predictors, the highest predictor was high virtual care. So if they had more exposure to virtual care, which is more than 85%, they had a very high likelihood of having that PD peritonitis. The other thing we realized that if they were located in an indigenous community, and that's not ethnicity, they were actually located in their own community, they had a very high likelihood of getting PD peritonitis. And of course, it was mostly failure of technique. And it was not related to mental health issues that was initially speculated during the pandemic, not related to diabetes as much. So none of those were significant. We had three significant factors: technique, indigenous location, and high virtual care, which was really interesting. And we followed up with interviewing those patients who went through it. And I don't have time to share this data. It's going to be published in Kidney International Journal anytime soon. It's been accepted. But essentially, the theme one that came out is loss of connection. So the patients felt disconnected to the system, and there was lack of trust. They did not trust health providers. There was so much misinformation, so much negativity around vaccination and everything else. They were like, we don't know. Who were you guys? And really that came down to loss of connection and trust. And of course, technique insecurity. So the patient later on admitted that they did not feel safe to tell us that they've forgotten how to do it properly, and they did not share that with us because they did not feel safe. And of course, many felt really judged and supported when the nurses would question them on the phone compared to the same assessment that would happen in person with a relationship with that provider. And of course, at that time, there were challenges when the nurses wanted to see through a video appointment or something. There were challenges with availability of Wi-Fi. As we know, Wi-Fi is not universally available in all the communities. So there were a lot of connectivity crises going on at the same time. So really what we learned from this study was over-reliance on virtual care. We know it's a solution. We know it can do a lot of good, but over-reliance in this situation increased the risk of infection. And indigenous patients were particularly, well, they were disproportionately affected through all this. So really what came out was we really need to invest in hybrid care model where we accept that, okay, a model of care which needs to be both blend of virtual and in-person care, and of course, built-in culturally safe care community-based supports, which were lacking at that time, and of course, address the training issues. So I'm just going to touch a little bit about the kind of birth of hybrid care here. So by hybrid care, what we really mean is combining virtual and in-person. And Dr. Ho already mentioned this could be peer-to-peer or peer, patient to provider. But the key thing about hybrid care, as we see it, is foundational our relationship. You know the provider who you've met before, who you trust. And that's the person you meet virtually. And that's the best gold standard of hybrid care. And it supports longitudinal and team-based care. And this is not the first time HealthLink Family Services developed this program. Many, many years ago, Dr. John Polich has been providing hybrid care, outreach and virtual both for many, many years, but it's not a standard care. It's not implemented in other organizations. First Nations Health Authority has a system, and of course, you've seen the RTVS pathways that really support hybrid care solutions. So why does it really matter? Well, it prevents the risk for rural communities to be virtual only. So you can imagine in this situation that there are communities who will totally rely on virtual only models and have no choice if this is an acceptable model throughout. But it does, hybrid does help to anchor care locally. So somebody's coming and visiting as a trusted provider. And it does support recruitment and retention. We're working towards creating that evidence, which is emerging. And of course, equitable access to specialists and advancing health equity. So leading up to this, we in 2023 got together a large bunch of us, and thanks to Kendall Ho, who's here, and John Polich, and many others on these pictures, as you see, a lot of support from the Rural Coordination Centre of BC, HealthLink Family Services, First Nations Health Authority, a lot of collaborative in terms of researchers, frontline providers, academics, and scientists and community members and patient partners. So we, the group came together really to build the research to create that evidence into hybrid care. And with the overall idea that we want to improve and standardize virtual healthcare delivery, leading up to a change in policy, fill service gaps and support the existing health workforce, find solution to address quality of care concerns, because that's the other piece, that if rural communities are only reliant on virtual care and they cannot get out, there is a concern about their health outcomes. And of course, promote continuity of care relationships. And of course, in the research that is developed, have a community voice and really bridging into cultural safety in the design. My apologies, I'm rushing because of time. So really, we have currently a study undergoing. It's called Health Workforce. It is funded and supported by CIHR. Kendall Ho is part of it. And really to understand the implementation of hybrid care in 2 communities. Right now, we're partnering with Takla First Nations, which is a Kirrisikanni community in north central BC, and Tumbler Ridge, which is in the northeast. So 2 communities where we're trying to understand the implementation. We want to co-develop the metrics to really look at the outcomes. And really, the idea is to support health workforce capacity and maximizing the scope of practice and building the team-based environment to support both primary and specialist care. I don't think this work is going to be entirely done in 3 years, but we'll hopefully have more evidence to support the importance of hybrid care, hopefully influencing policy and implementation more across. The approaches we're taking is more strength-based rather than what is lacking. So again, don't have time to go into this, but very much aligning Indigenous worldviews, storytelling, relationship building, and so on. This is an example of the workshops we've done, some pictures led by, this is a workshop in Prince George in June this year. This is the leadership from Takla First Nations, some circles in Takla First Nations to initially talk about this project. We have elders guiding our pathways. And this is some of the graphic recording done during our workshop by our Indigenous artist, looking at what we need to do in terms of discovery and dreaming phase of the work that is ongoing right now. Okay, so really to wrap it up, the key takeaways are geography or rural location should not determine kidney or general health outcomes. We've seen it has a potential for determining kidney outcomes, but that should not be the case. We know virtual only care models can create unintended harms. So we need to approach it with caution. We think hybrid care, which is relationship based, is the path forward that blends in person and virtual care, really supporting trust and safety. And of course, closer to home. And community-led design is very essential for sustainability. So I'm just going to stop here. Just want to thank the folks involved with this, the organizations, and yeah, happy to take any questions.
Fabulous. Thank you. Thank you so much, all three of you, Pacific Blue Cross and the virtual care research and the bringing care closer to home. Thank you. And if everybody on our call can join us in thanking these people for this fabulous presentations. We've got a couple little questions in the chat, and then I'll open it up to everybody to ask their questions. There's a lot of relevance here to our rural work and our rural partnerships and our rural communities. First question came from Danette, and I believe she had to get on a plane. It's for YMCA. They're asking about whether or not Y at Home is available to non-Pacific Blue Cross clients.
All right, it took me a little while to get off mute. So yes, it's available to everybody in the public.
Oh, fabulous. Okay, thank you. And then the other question was from Ed about how widely used the Y at Home program is.
That I actually don't have a lot of information on. I'm happy to take that away and bring it back.
Okay, that's perfect. Thank you. Okay, any other questions now for any of our presenters? Well, while you're thinking it out, oh, here, Ed's got a question. Sorry, Emma.
I've got a quick question for Anurag. I know some of the work that our T2D network does in a rural setting. There's quite a lot of different programs going on in a small community, and you mentioned Tumbler Ridge as one of the communities that you're engaged in. And I know that's a community that one of our other partners is engaged in as well. Do you find that you've got these smaller communities that are kind of that have fatigue from all of these different programs going through all of these different avenues in the health system, and that creates conflict? Or do you find they work well together in a rural setting? Just some commentary on that would be appreciated.
Sorry, Ed, was that directed to me? Because I'm not sure that I...
Oh, sorry, Anurag.
Okay.
Sorry. Am I pronouncing your name correctly?
You did. Thanks, Ed. Sorry, there was some other names. So how we approach, and Kendall is part of that. He's a principal investigator in that study that I'm talking about. So we approach these communities to express interest first. And it was a pathway that we used through organizations so that we don't sort of select communities. So Tumbler Ridge approached us rather than us approaching Tumbler Ridge. And they wanted to partner with us in this study. And I must say, having worked with the physicians there and having worked with the leadership, the mayor and everybody else during our visits, it's been amazing. They're very excited. And yes, there is a lot going on. Sometimes you're right. There are a lot of, there was a project on diabetes. There were several things going on in the community. But, my feeling at that time was that they wanted things to change. They understood what we are providing is they're contributing to research. We're not going to be able to fix their emergent problems while we're doing research. We're going to help sort of with long-term solutions. So that was kind of sometimes hard because when you go with a research priority in a community, people think that you're going to bring providers, you're going to change their situation overnight, right? So that's the kind of perception sometimes we have to kind of address right at the beginning, but that's a great point. We do see competing priorities as a barrier sometimes in First Nations communities that we've engaged in. We've had to pause engagement because they have lots going on, and they don't have time dedicated to engage with us, even for something which is their priority. So things do shift, and we appreciate that. And that's the thing about rural research. It's not very straightforward. If you really need to do this, you have to be patient and make sure you go back and ask permission. I hope this addresses your question.
Yeah, understood. Thank you. I mean, the difference between research and actually addressing the core component quickly is a great one to highlight, because some of our projects start with that research component. It's so crucial to identify that that's the start, and the action comes later when the research has been evaluated. So thank you very much.
Great. Thank you, Ed. I've got a question in the chat from Tony from Simmons, and it's directed toward Dr. Ho. And he's interested in what platform provides the backbone for the health service, particularly the video capability.
Great, thank you. If you don't mind, I'll quickly add to a little bit of what Anurag said in last, and then I'll go to this one.
Sure.
I really appreciate Anurag leading the study of workforce, really a tremendous leader. I'm following him, behind him, so I really appreciate that. And he has it completely right. It's about first active listening to the community, and also to understand where they come from, and then we can then kind of use that, not use, but leverage the relationship to then design solutions. I think what Anton said earlier on is also very, very important. In urban communities like Vancouver, it's nice to, you have this, you have this, you have this, looks like a variety of things. In fact, in rural communities, they do all that. They do all that already. And so sometimes when we go in with a research project, we actually end up siloing them while the service has been really intact. And so that active listening and relationship building becomes such a fundamental piece to make sure that hybrid care is integrated, to make sure that the communities are listened to. And then over time, we continue to support the community for what they need. Tony, as for your platform, we use a Zoom as our current platform over the last 5 years for the video conferencing front. And on electronic health record, we use MOAS as one of, there are many different electronic health record. We end up using MOAS as the electronic medical record. And then once we've seen the patient, we then upload the charts into something called Care Connect. So all electronic medical records and hospitals can access that chart. And so both the peer-to-peer support and also the First Nations Health Authority and also 811 all use those platforms.
And is it possible to bring all of that data to bear on in real time, the virtual visit via a single platform? So you can bring everything forward, you can be looking at all the data and having the interaction with the patient at the same time?
Yeah, not yet, but there's several things that has caused that to improve. One is for all of us that practice virtual care, we have access to Care Connect. And so when we talk to the patient, we have the ability to pull up the patient's own personal portal chart with the patient's permission, of course, and then also previous visits. So we can see it, but Care Connect is not a true electronic health record in the sense that it's a viewer, but it doesn't go into your record in a solid way. So I think as the province move forward on provincial electronic health record, we're hoping that we can continue to integrate further and further into electronic record itself.
Thanks very much.
Thank you, Tom.
Thank you. Does anyone else have a question?
The Chetwynd Chamber just asked if there's been, in the chat, she just asked about emergency room closures.
Okay. Yeah, as I'm sure looking for a question there, specifically.
I had a member come in, and I'm in an office of one, so I'm not sure if I missed something. So emergency room closures is a big topic, and I know I just heard about, talking briefly about Tumbler Ridge, and Tumbler Ridge is having their own giant set of issues with their healthcare. We experience several emergency room closures a month, way too many. So when that happens, we are told to go to other communities. So Tumbler Ridge gets told to go to Dawson Creek or Chetwynd. Chetwynd gets told to go to Fort St. John or Dawson Creek, but they're experiencing issues as well. Has there been discussion? Did I miss anything on any solutions to that or anything like that?
So I can briefly address. So there is representation. So when we went to Tumbler Ridge, clearly Northern Health is a partner in our research project. So this is kind of research to understand the barriers and potential solutions. So the members of the South Peace Division of Family Practice, who also support the emergency departments, both in Tumbler Ridge and in Chetwynd, are part of the discussions. So we're, next time we come to Tumbler Ridge, I can reach out to invite people broadly. There was a lot of gathering this time when we went, and our plan is provincially to come back again in Tumbler Ridge in July for the medical conference. But it was widely attended. So again, the question is that we're not there to bridge emergency requirements right now. We're trying to understand to have a more sustainable solution using virtual care tools or hybrid care tools.
Right. Yeah. I know when the Minister of Health came to visit the Northeast, it's very rare that we get a minister up here. And the one thing that we did notice is that chambers were not included in that conversation and in the meetings with them. And I always say this, you remember your chambers of commerce. We are the voices of our community, of our businesses as well, and our local economy. So when you have meetings, and you're bringing ministers up, please always try to include your chambers of commerce. It's an absolute vital connection. Chambers have a direct, I always say a direct connection to be involved in healthcare. And I fight it at the BC Chamber and at the Canadian Chamber as level as well. But we are connected to that. If we don't have healthcare, we don't have businesses. We don't have, it's a connected circle. So I just always like to say, involve your chambers of commerce.
Thank you so much. I agree. That's why we are the linked sectors. That's why we're here. We have some representation from our elected officials on the call, and just that's why we are linked, and we really want to make sure that all sectors have a say in healthcare in their communities. If there's no more questions, I will let you say thank you to all the hosts. Are there any more questions? Kathleen, please step away. Oh, yeah, sorry, Tony. Yeah, go ahead.
It was just one more question again to anyone on the call. What's the plan to address, you mentioned, Dr. Ho, I think a couple of you mentioned the technology limitations. What plan is there in place to address those limitations, like access to lack of access interruptions, that sort of thing? Is there a significant investment being made by the government in the backbone? Anyone can answer. Anurag, if you have any insights, or Anton.
Hi, Tony. So this is kind of I would say beyond the scope of the work that I'm doing. We're certainly advocating for, digital divide is a huge problem. There are many communities who we want to serve don't have the reliable internet and Wi-Fi and so on. So it's an ongoing process, but I would say, work through your elected officials in your community, like the community we're working with, Tumbler Ridge, for instance. Their mayor is very activated and they want to upgrade their broadband system. So I think it depends on every community, but as your healthcare providers or researchers, happy to advocate with research and evidence that is required. So our job is to create the evidence that would support the need.
Thanks.
Thank you very much.
Thank you.
Are you good with that, Tony? Can we move to Carrera, or you have follow-up? Awesome,
Very
Carrera.
Good. I don't want to take. Can you hear me? Sorry. I don't want to take up too much time because I know we ran over, but I think it's such an incredible question, Tony. And it's it's another kind of almost siloed area. There's so many folks working on that. Some of it potentially is policy change within our governments to open integration and conversations around Bill 72 at the federal government level, those kind of aspects of things. But it's such an important conversation and a great question, Tony.
Has Canada Health Infoway been involved at all? I know that's one of their mandates.
They are absolutely working on it. I can just speak from I lean in with the personal health records project with RCCBC, and so we kind of aware of all the different aspects of the work, and there's so much great work out there that we could almost have a whole other conversation around that for sure. Yes.
And that's perfect. That's actually what our January 20th next link sectors. You guys like, is this part of our script? It's like the segue is about
How we
fantastic.
worked it, Sarah. It's just
Yeah,
how we
thank
worked
you
it.
so much. You guys are amazing. So the use of and access to data is what we're going to be talking about on January 20th. And that will be hopefully Anton and his personal health access to your personal health records and other topics like that, that just accessing data for as a patient and community and practitioner, like the whole systems piece. So yeah, if you know any speakers that we haven't got our agenda fully laid out yet for January, so feel free to, if you have someone that you think should be attending these calls or be there. Yeah, this was great. And thank you so much to all our presenters today. We really appreciate it. Thank you to Paul Winwood for putting me together with Anurag and Kendall. So thank you very much. And as well, always to RCCBC for facilitating this. This is a wonderful group of people collaborating on health and for rural, remote, and First Nations communities. So we appreciate it. I will be on my slow Wi-Fi. It takes about 24 hours to upload this, but I will be uploading this on my rural Wi-Fi to our website, and I'll send you all a link. So if you want to share it out afterwards. But once again, thank you all for staying on, and thanks again for presenting. Feel free to reach out to any of us if you're looking for more information. Yeah, we're here for you. Thank you again.